Thank you very much for kind introduction, and thank you very much, Manoj Chawla sir, Purvi ma'am, and whole organizing committee of DRS again for having me here. So my topic is AI for GDM detection and better outcome. So definitely the previous talk was on CGM fatigue, and I would say we all have now AI fatigue as well. We should keep at least one or two conference without AI now, and we should try at least, as we are tired listening to AI, but we don't know how to use it, and this is what I'm going to show in for GDM. First, we need to understand this flow chart. Every time when I start any presentation, hyperglycemia in pregnancy, we need to understand this flow chart of diagnosing hyperglycemia in pregnancy, where hyperglycemia in pregnancy is an umbrella term. Diabetes in pregnancy and gestational diabetes, these two things comes under hyperglycemia in pregnancy, where diabetes in pregnancy, when HbA1c is more than 7, whether you diagnose before pregnancy or after pregnancy, it is type 1 or type 2, then we call it diabetes in pregnancy, and we should try to write these terms in our prescriptions as well. But today I'm going to talk is gestational diabetes, which is around 80% of hyperglycemia in pregnancy. So I'm leaving this 20% of diabetes in pregnancy and only going to talk about gestational diabetes and what could be AI predictors for the prediction model of gestational diabetes, or even screening, or even to prevent type 2 diabetes, what kind of data we have that I'm going to present today. So we all know about DOHAD society, right? DOHAD is the most important thing, and it always talked about pregnancy is the window of opportunity or window to future health, and the physiologic changes act as natural stress test for the body, and glucose intolerance causing hyperglycemia is one such condition. So it is an inflammatory state when GDM is there. So we definitely can prevent type 2 diabetes or even obesity in future. This is what DOHAD always tried to explain. So the growing challenge of gestational diabetes, where it ranges from 4.3 to 38% of gestational diabetes worldwide. So you can see how the range is wide. 4.3 to 38%. So we don't even know how exactly the percentage or in different countries. And even in our country, if we see, gestational diabetes is around 11% to 20%. And we don't have exact data even in many of the states. We don't have prevalence data. Even if I say in my state, in Gujarat, we don't have prevalence data of gestational diabetes. We are trying to put a study for prevalence of gestational diabetes in Gujarat as well. So globally, the prevalence of gestational diabetes is not concise, and it is around 20% according to MEDO GDM study. And this is AI-based study. I'm going to talk about it in next few slides. So health risk. Increased risk of preeclampsia, neonatal complication, and long-term metabolic disease for both mother and child. This is the problem with gestational diabetes, and critical timing, where early detection and intervention are essential to reduce morbidity as well as mortality in future. So current gestational diabetes screening limitations and barrier. IAD PSG criteria or ADA criteria, they have they have multiple times you have to screen the patients, and also fasting, post meal 1 hour and post meal 2 hour. So this multiple blood draw is a big problem. So if we have a prediction model before pregnancy, and if we can put this data and we can come out with something that can be really helpful in high risk category, though India is high risk category, so we know that this is a universal screening is there for all of us, But if we can come out of this, and by DIPSI screening model only, we can come up with something constructive that can be really helpful for screening, and less drawing of blood can be helpful. So key challenges here is patient burden in our population, access limitation, so limited availability in low resource setting. This was also stated by Mido GDM in 2023. This was Mexican study. So pandemic impact also was there, where COVID-19 further reduced diagnostic capacity globally. So in such kind of pandemic, how we are going to predict that that patient could have gestational diabetes, that could be, in such situations, AI could be really helpful. So why AI transforming GDM screening and prediction is important, where traditional pathway of screening, where it could not be helpful. Standard OGTT window is also one of the bigger problem between 24 to 28 weeks of pregnancy itself. Says this window is a problematic. AI early prediction, even before pregnancy, when we put the risk factor for this patient, for particular patient, and if we have application, and it can predict that this patient is high risk category for gestational diabetes, that could be really helpful. So early intervention in such cases also is one of the key to prevent metabolic disorders further. So this Mido GDM study done in Mexican women, and it's an innovative artificial intelligence based prediction model for development of gestational diabetes. So here you can see what they have done. They have put multiple risk factor: age, family history of type 2 diabetes, previous diagnosis of hypertension, pre-gestational BMI, gestational week, parity, birth weight of last child, type of capillary glucose measurement first prenatal visit, capillary blood glucose level, also 9 inputs nodes, and they came out with one GDM outcome. And what was the key risk factor identified in this Mido GDM study? It was BMI. If BMI is more than 38.6, then the patient has higher risk of gestational diabetes. This was for Mexican. For Indian, it could be lower BMI, but we should have our own data like this, and we can even replicate this kind of model in India with all the data input. Abdominal circumference more than 91.5, again it could be lower in our Indian patients. Fasting plasma glucose more than 4.5, so it is quite striking, around 90 mg per dl it is, and if it is more than that, then this women have higher chances of gestational diabetes. So pre-pregnancy fasting plasma glucose of more than 90 mg per dl. So this demonstrated potential for early GDM risk stratification before standard screening window, and clinical impact of this Mido GDM could be diagnosis, and ultimately it can translate into outcomes as well. So early GDM diagnosis before 24 weeks and linked to lower rates of neonatal hypoglycemia, birth trauma, NICU admissions. But recent study of Tobo GM did not favor such things. It said that early GDM prediction does not make very big difference. Like before 20 weeks, if you screen and the GDM, and if you diagnose GDM, it does not help in overall outcome. It is about pure gestational diabetes. So long-term benefits, potential reduction in future metabolic disease risk for both mother and child. Again, I'm saying this. Extended intervention window. AI model can identify high-risk pregnancies earlier than standard OGTT time. Optimize treatment for early initiation of lifestyle modification and pharmacological intervention when needed. So, again, some apps like this I have already been built up, and this apps can be used, but this app should be country-based or localized app should be there, and it should not be universal app, as I said, that it can be different for India, what was shown in Mexican study. So an innovative artificial intelligence based app for diagnosis of gestational diabetes and we can even ask RSSDI for that we can build such kind of app for gestational diabetes, or even under the guidance of DIPSI we can develop such apps where clinical data build the mathematical model to predict health status of pregnant women based on clinical data. So post-market data collection, where collect the data of pregnant women, which will undergo continuous training on the model, and goal of such kind of application is to input the data and relate it to their health status, and the application can predict future disease status. So AI based GDM diagnosis app, where clinical validation says that support vector machine can be useful rather than using random forest or even neuronal network. So machine learning derived prenatal predictive risk model for guide intervention and prevent the progression of gestational diabetes to type 2 diabetes. So the data of women of gestational diabetes, if we have good number of data that can predict type 2 diabetes in that women in how many years, that we come to know. So this study done in Singapore, this study is noted as the first to use machine learning for postpartum type 2 diabetes risk assessment in Asian antenatal population. The model has potential for early risk stratification during prenatal care, which could facilitate preventive interventions. So machine learning for postpartum of type 2 diabetes, which can help in early prediction, clinical application, and advanced algorithm. So the best performing model used mid-pregnancy BMI. So it was mid-pregnancy BMI, which was the better predictor for type 2 diabetes from gestational diabetes, then achieving an area under the curve, and mid-pregnancy BMI after gestational weight gain was the better predictor than pre-pregnancy BMI. So machine learning based prediction of large for gestational age infants in mother with gestational diabetes also can be very much useful. So AI models using novel CGM derived in, so CGM also can be one of the best predictor. So CGM derived metrics from as early as first trimester have demonstrated significantly higher accuracy for predicting GDM. So you can use CGM in first trimester to predict gestational diabetes. This is what machine learning of this study is saying. So AI based model can combine real-time CGM data with other clinical information such as BMI, demographic data to predict the risk of adverse pregnancy outcome as well. So I guess my time is over. So I'll summarize now. So that AI as a catalyst of better GDM outcome, where early detection, enhanced outcomes, improved accessibility, and collaborative implementation can be there with the use of AI in pregnancy. So this presentation I presented was crafted using AI, powered by AI, but brought to life through the spark of human intelligence and creativity. With this, I will conclude my talk. Thank you very much for patient listening.